appreciate your patience. Now I'd like to turn things over to our moderator, Bob Mays of AHRQ, who will introduce our panel. Bob, please begin.
Thanks, Dean. Welcome, everyone, to this National Web Conference sponsored by ARC. This conference is actually the third and final one in a three-part series in which we've been exploring electronic e-prescribing as well as electronic medication management in general. The first couple of conferences, we looked at the current state of electronic medication management and focused primarily on aspects of e-prescribing implementation, both from the prescriber's point of view as well as from the pharmacy's point of view. In today's conference, we're actually going to take a look at where things are headed in the impacts that e-prescribing and electronic medication management will have on practice in general, and also to examine a couple of the issues and challenges that we're going to face as we move towards a more universal adaptation of this kind of technology. We've got really two good speakers today. Dr. Michael Fisher is an assistant professor of medicine at Harvard Medical School, as well as an associate physician in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital in Boston. Dr. Fisher has done wide research in the area of both e-prescribing and broader electronic medication management, looking at issues around electronic prescribing, medication adherence, reimbursement policies, as well as appropriate use of prescription drugs and the complications that can ensue from drug therapy. He's going to the impact that e-prescribing is having and will continue to have on the practice for patients, providers, and pharmacies. And he'll also talk about the future directions where we're going with research in this, as well as some of the challenges that we're going to face as we move forward in this field. He's then followed by a presentation by Dr. Grant Carroll. Dr. Carroll is Deputy Director of the Bureau of Healthcare Safety and Quality in Massachusetts Department of Public Health, and he's also the Director of the Public Health Department's Drug Control Program. Dr. Carroll has done a lot of research and is currently the principal investigator on a number of grants looking at the issues surrounding electronic prescribing of controlled substances. And he's going to talk about where we're at in that area today. That's been a big problem in terms of overall adoption of e-prescribing, and as many of you probably know, the Drug Enforcement Agency is in the process of putting together some new rules and regulations around e-prescribing of controlled substances. And Dr. Carroll will talk a bit about the challenges that are involved in that particular area. We'll have about 30 minutes for each, 20 to 30 minutes for each of the presentations, and then we'll have a question and answer period. There is a Q&A panel on your screen, and you can submit questions. I'll be monitoring the questions submitted during the presentations, and then at the end, we'll direct those questions appropriately to either Dr. Fisher, Dr. Carroll, or both. In the past, we found that a lot of times people ask very similar questions. So what I'll do is try and combine those that are similar just in the sake of time. We will, however, answer all of the questions when we post the video of the conference on the website, I was just pointing out, in a couple of weeks. So if we don't get to your specific question, we will, in fact, provide an answer for it, or it may be combined if there were several other questions that were similar. So I think with that, I'll go ahead and turn it over to Dr. Fisher, and we can begin the conference.
Super. Thanks very much, Bob. So as Bob indicated, what I'm going to talk about today for the third of these conferences, and maybe appropriately as we wrap up the summer and everyone gets ready to get back to the academic year and the work year, is where do we really stand in terms of what we know about e-prescribing? What has been demonstrated so far, and what do we still need to learn and understand as we move forward with wider implementation of e-prescribing? To give you an overview of what I'm going to talk about, the promise of e-prescribing is something that has been widely touted by clinicians, by researchers, certainly in the policy arena, as I think anyone who's interested in this topic and logged on to this call knows. People, e-prescribing has appeal across the political spectrum, people from Newt Gingrich to the president and everybody in between. Talk about the promise of e-prescribing to improve multiple areas of medication use, to make it substantially better. But what I want to do today is really talk about that promise, but review the evidence to date, both quantitatively and qualitatively. What do we actually know about where e-prescribing delivers on that promise, and where is that promise still at the promise stage, still something that's unproven, and talk about some of the remaining barriers to really achieving the potential of e-prescribing. I'm going to focus on the areas listed on this slide. I'm going to start with drug safety, which is where many of the initial benefits of e-prescribing were identified, at least the theoretical benefits. Talk about the efficiency of prescribing processes and medication filling processes. Then talk about medication costs, and finally some of the barriers to adoption and use that remain. Now, I'll give away the ending right here, since this is not meant to be a mystery presentation. My take on the evidence, and I'll lead you through some of that work and hope that you'll end up agreeing with me, is I do believe the proponents who say that e-prescribing has the potential to improve patient safety, to increase the quality and efficiency of prescribing. However, the evidence that these gains can actually be achieved in the outpatient setting and with our current systems really is still being developed. And at this stage, we haven't, for the most part, and by we here I mean really the research community, been able to demonstrate conclusively the potential gains in the outpatient setting. And to get the full adoption of e-prescribing and full effectiveness of e-prescribing, we're going to need to aggressively go after the barriers to best use of e-prescribing, understand what are the most effective practices, what are the most effective interventions in e-prescribing. So let's jump into the specific topics. The first area that I mentioned in that outline is safety. And the promise of increasing drug safety through e-prescribing has been probably the most widely touted. I think anecdotally and on sort of a personal and emotional level, it's really the legibility problems that seem to have the most appeal to the public. The idea that with e-prescribing, one won't need to deal with doctors' messy handwriting anymore, and I think everybody has heard a variety of anecdotes about that. That's great, but that only takes one so far, since most legibility problems actually led to inefficiency as opposed to errors in the past. It was relatively uncommon for pharmacists to randomly dispense a drug. It would lead to inefficiencies in the process. On the other hand, there's a strong suggestion that better information at the point of prescribing really could improve the safety of drug use. Going back several years, the Center for Information Technology and Leadership did a study where they estimated that 1/4 of adverse drug events, ADEs, could be avoided if that better information was provided across a number of areas. Better information about patient allergies to avoid those kinds of reactions. Better information about drugs and drug lists to avoid drug-drug interactions that harm patients. And generally the kind of clinical decision support that allows physicians to prescribe drugs more safely, pharmacists to dispense more safely, and patients to use more safely. Identifying doses that should be avoided, or adjustments of drug frequency that need to be made for patients' comorbid conditions. Adjusting the dose or type of medication used based on a patient's age or other characteristics. That's really the promise that is there for e-prescribing and safety. Well, how about the proof of that? Well, there's a lot of very good proof that electronic prescribing in the inpatient setting, usually when implemented as part of a computerized order entry system for inpatients, can really improve patient safety. These studies have been done in a variety of settings at Partners Health System here in Boston, at Regan Street, Intermountain, the VA, several other large centers where they have looked at electronic prescribing for inpatients and shown a definite reduction in drug errors in terms of drug-drug interactions, dosing errors, even the ability to guide specific and more complicated areas, such as antibiotic management, such as prescribing dose adjustments for the elderly, some work that some of us did here on use of high-risk medications, biologics, and other medications used for severe sepsis. But this is all in closed inpatient settings. In the outpatient setting, the data so far in terms of increased safety have really been qualitative in focus groups, interviews. Physicians talk about their ability to review medication history and know what patients are on when they prescribe. Identifying patients on high-risk drugs, for example, in an evaluation that we did recently where the nurses working in a practice, when the black box warning for Avandia for rosiglitazone came out, were able to identify all the patients in that practice on rosiglitazone and reach out to them. The ability to avoid tampering with prescriptions, again, is qualitatively been identified as something that may improve safety. However, the pitfall here, the problem, is that the quantitative outpatient data are really very limited, and in fact, the data that there are so far are not as encouraging as we might hope. This goes back several years. Tejal Gandhi and her colleagues here in Boston did a study looking at several ambulatory clinics that had adopted e-prescribing systems and found that the e-prescribing in and of itself did not appear to actually reduce the drug errors in terms of what was dispensed to patients. One of the reasons for this may have to do with the systems that we currently use. As you may recall in the introductory slides, I mentioned that one of the issues is, have we been able to demonstrate improvements with our current systems? Well, in our current systems, most alerts that appear, most safety warnings, are overridden by prescribers. Saul Weingart demonstrated that in a paper in the Archives of Internal Medicine back in 2003, and he was actually the senior author on a recent paper that Zach Isaac and others collaborated with him on, showing that that continues to be the case now, 6 years later. And Kate LePaine and her group have done some work trying to look at why it is that the alerts in current systems don't seem to have the clinical relevance that prescribers would hope for, that when they see those alerts, they most often dismiss them. In addition to the current alerts not necessarily being what prescribers are looking for, another pitfall is the possibility of new errors. This, again, is something that's not been quantified, but is a concern for patients, for physicians, and for pharmacists. The possibility of selecting the wrong patient or selecting the wrong drug when many things are done on drop-down menus, and the idea that when those are transmitted electronically and there are not legibility issues, it shows up, it's printed, it looks official, that things may be dispensed. Pediatricians in particular have struggled with problems of certain doses or formulations not necessarily being in their e-prescribing dictionaries. All of these are problems that can be addressed, but these are the barriers that systems face right now, and these barriers seem all the more pressing when we don't have the strong quantitative proof of increased safety from the use of e-prescribing in the systems that we currently have. So the challenges for increasing safety, and I think this is going to be one of the really critical areas over the next couple of years, as more and more prescribers adopt e-prescribing in response to some of the financial incentives coming from the government, to really have that be sustained use and meaningful adoption, it's going to be incumbent to identify what works in terms of safety and to really define true gains in safety, as opposed to efficiency gains where we might avoid a callback from the pharmacy, but we haven't actually caught any additional errors that might have gone through. We're simply moving the location of catching the error from the pharmacy to the doctor. I'll talk more about that in a minute, but I think it's incumbent on us to define true safety gains to really convince providers of the utility and to convince patients of the gain for them from electronic prescribing. A big piece of that will be improving the acceptability of alerts, and there's a lot of work going on about that now. A little bit has been published previously on trying to fine-tune alerts to increase the acceptance rate by clinicians, but that's an area of active research right now and one that is likely to be very, very important in the coming couple of years. Another important element is developing the data infrastructure to support more robust safety interventions. So strong connectivity to other systems, allowing for things like medication history, which increasingly is being provided so that clinicians can know what medications patients have been on in the past, what medications they might not have tolerated, what other medications they might be on that could interact with the meds that they're trying to prescribe. Linking to electronic medical records and other inpatient and outpatient systems to provide that complete clinical data, and understanding how we're going to get the clinical data into the e-prescribing systems. Is it by connectivity? Is it going to have to be done manually? These are the infrastructure challenges that we're going to need to confront. Now, beyond safety, the next topic I want to talk about is efficiency. And although in the safety section a moment ago, it may have sounded a little bit like I was running down efficiency as a concept. We want gains in safety, not just gains in efficiency. Well, just gains in efficiency are not a trivial matter, and although I think safety is an issue that resonates much more with clinicians and with the public, efficiency is a significant issue. Back in 2004, the Department of Health and Human Services had a study where they estimated there were 1 billion callbacks per year from pharmacies to prescribers to clarify problems with prescriptions. At every level of the system, that's a tremendous impact in terms of time used that could be used in other places. And I think everybody here knows time is one of our most precious resources in terms of getting anything done. And beyond the time at each level of the system, for patients, in addition to the time, when callbacks are needed, when their prescriptions aren't ready, there's more and more of a risk of them walking away from that prescription, not adhering to the medications they've been prescribed. Pharmacists find the callbacks a major distraction that prevents them from doing the counseling of patients, from attending to other clinical tasks that they need to. And for prescribers, of course, the callbacks really interrupt their workflow if they've given a prescription and are getting a callback when there's several patients further in their day. And these inefficient processes really are throughout the system, and one of the promises of e-prescribing has been to make that all work better. The proof is really relatively limited so far in terms of quantitative proof, but it's an area where I think there is a great deal to gain by convincing prescribers especially of the benefits to them in terms of efficiency. There's a lot of qualitative data on efficiency. Our research group has done some focus groups, as have others who've done focus group surveys and other qualitative research, identifying some of the areas that are really important to prescribers and to pharmacists in terms of efficiency. The ability to avoid lost prescriptions, the reduction in callbacks, which we talked about on the prior slide, the ability to group prescribing tasks, for example, to batch requests from patients for refills and renewals, for large practices is a huge gain in efficiency that really makes a difference in their ability to manage workflow, their ability to manage patient medication lists. And these kind of qualitative data really do have an impact in terms of helping prescribers see the benefits to them of e-prescribing. But the challenge remains that there really isn't quantitative data, and so for providers, the role of e-prescribing in terms of making their workflow better, making them more efficient in the office is less clear. One way that the current political environment that people are working around this is simply providing a direct financial incentive, and that certainly works very well, as I think people are aware. Having a financial incentive to do so definitely gets people adopting e-prescribing, but for it to be sustained use and for it to be meaningful use, and I mean that in the broad term, not in the specific meaningful use sense, which can be a loaded term, but for it to be important use by providers, they really need to see the benefits to them. And there are a lot of threats to that gain in efficiency that can undermine the adoption of e-prescribing. And it doesn't take very much. It only takes a couple of bad experiences to really sour a prescriber or a practice on e-prescribing, and that's something, again, that we've seen in qualitative research. When there are connectivity or reliability problems, especially for smaller practices that maybe are not embedded in a large center, that can really decrease their productivity for the day if all of a sudden the system they've become dependent on isn't working, and they may find themselves much less likely to rely on it in the future. Similarly, the fact that e-prescribing is not as seamless as we would like, that not all systems can transmit to all PBMs, which requires printing some prescriptions, the inability to e-prescribe Schedule II meds, and I'll touch on that only briefly because Grant's going to really highlight the importance of that topic. But you put all this together, you may have a prescriber seeing a patient and e-transmitting some of their meds, printing some for them to mail to a PBM, printing some for them to carry to the pharmacy as a Schedule II. It's not the efficiency gain that the prescribers are really looking for, and that's a major challenge that projects like Grants are working very hard to address. Controlling costs is an area of a lot of focus, of course. Seniors often are where we hear the most about it, but really for all populations, drug costs are a major concern. And there's been a lot of research identifying the savings that could be achieved from using less expensive but equally effective medications. Simple generic substitution of identical chemical agents for the brand name entity has been demonstrated in a large variety of studies to have the potential to save many millions or even billions of dollars. Therapeutic substitution here refers to, for example, the use of inexpensive generic and effective medications like thiazides and ACE inhibitors for hypertension in place of more effective agents. And those potential savings, it's been demonstrated that they're out there. The question with e-prescribing now is the promise of getting there, of actually controlling costs. Beg pardon. As a secondary downstream improvement in cost, there's also research that suggests that there's better adherence when patients start on medications with a lower copayment, and especially for drugs for conditions like high blood pressure, diabetes, high cholesterol. If you can get patients to stay on those drugs, you're likely to see a real benefit in terms of downstream medical costs due to the effectiveness of these agents. Well, there has been some quantitative proof in this area from our group and others. In our study from last year, we looked at the ERX Collaborative here in Massachusetts, which put formulary decision support into an e-prescribing system. So this was a relatively simple kind of formulary decision support, simple color coding of how the drugs appeared to the prescribers, with preferred drugs in green fonts, non-preferred drugs in red fonts, and so on. And with that relatively straightforward, non-intrusive intervention, there was a shift from brand to generic prescribing. And when we did our study, even accounting for increases over time in use of generics, which have been happening, as a lot of you know, and for differences between doctors who re-prescribe and doctors who don't, even after we controlled for all those, there was an additional 3.3% increase in the use of generics, which corresponds to a pretty significant savings per member per month for the insurers who are paying for these populations, or for the individuals if the patients are paying out of pocket. So that's a quantitative benefit that really can make a difference for patients and for whoever's bearing the cost of the system. There are also some qualitative benefits that have been identified. The ability to discuss costs with patients at the time of prescribing, to say, hey, you know, this is a drug with a high copayment, identify potential barriers to adherence up front, as well as the ability to identify patients on costly medications. And again, this is something for specific practices. When a new generic agent comes out, for example, and they want to let all their patients who are on the expensive brand name drug know, you can get onto a less costly treatment that may be easier for you to afford, easier for you to adhere to month to month. It's easy to get a list of who all the patients are who might benefit from that. There are still challenges in this area, though. The study that we did was based on a lot of work by a couple of insurers and e-prescribing vendors here in Massachusetts as part of the ERX Collaborative to make sure that the formulary data were current and accurate when decisions were being made. Even with that, we found that when the doctors in our study weren't using their e-prescribing system, when they were writing non-electronic prescriptions, the increases in use of generics went away, and they went back to the baseline, the level they would have been at without the e-prescribing. So the data really need to be there and in front of the clinician at the moment of e-prescribing, of making that drug decision, in order to actually have an impact. I mentioned medication adherence in terms of cost, and this is another area where there's a potential for improvement. This has become a focus just in the last year or two as a potential area where e-prescribing can make a difference. Non-adherence to chronic medications is common and limits the effectiveness of medications for conditions like high blood pressure, like high cholesterol. And it's been recognized that as the connectivity in the system gets better, e-prescribing has the potential to improve adherence, and it's a place where e-prescribing could really demonstrate its value. Medication history has the opportunity to identify when patients are non-adherent, when they start on a drug and then stop filling their prescriptions over time. And as e-prescribing systems become more sophisticated, the ability to deliver interventions via e-prescribing holds a lot of promise for addressing this issue. There are still major barriers, though, besides the areas where we haven't demonstrated benefit. Just in terms of getting clinicians to e-prescribe, the adoption until the last year or so has been relatively slow. It has really picked up dramatically as money has gone on the table, both in terms of direct incentives and penalties, and that has driven a lot of initial adoption. However, the traditional barriers to adoption have been not just cost, and we're doing a lot to address cost either by, as I said, providing funds or making the cost of not adopting higher, but the learning curve is another major issue. And depending on how we do with that learning curve, how all these new adopters are doing with the learning curve, will determine whether the adoption that's going on right now in many, many practices is actually successful and sustained, or is something that is partial and incomplete. The real barriers to getting people to sustain e-prescribing are several of the points, the other points on this slide. They need to see that the systems are usable and reliable, that they're interoperable with other systems, billing systems, other clinical systems, and that connectivity can be maintained reliably. Once practices come to depend on these systems, it's very important to them that they stay connected all the time, and any downtime becomes a major barrier to sustained adoption and long-term use. There's a perception out there of patient resistance to electronic prescribing, that patients expect to leave with something in their hand. And that's something that's going to need to be addressed over time that I think patients are becoming more comfortable with, but remains a major challenge. And then, of course, although interoperability, although connectivity are huge priorities to all of us who do clinical care and to those of us who do research, we see those as a benefit. Of course, there are major concerns about data security as we make all of these systems try to work together better and better. So how do we overcome some of those barriers to realizing these gains? One of the important things is making e-prescribing positive for practices, not just giving them the money up front, but providing especially smaller practices with the support, with the interoperability for e-prescribing with their other systems, and figuring out what are the areas that matter to prescribers. One of the things the research to date has showed us, for example, is that although everybody agrees that drug safety is an important priority, the alerts that we've designed don't seem to address the areas that matter to prescribers. When they're presented with drug safety alerts, they mostly dismiss them. And so we haven't succeeded yet in finding the way to make what we're presenting matter to prescribers in a way that's going to improve their practice. Demonstrating patient preference also could have a large impact. Providers tend to want to do what their patients prefer, and that's an area that could really make a difference. And ensuring the reliability and security of systems, the power of the negative anecdote is very strong. When prescribers start adopting a system and it's buggy or it goes offline, that can really impair their willingness to stick with it long term. So the more we can ensure the reliability and security of these systems, the stronger and more sustained the adoption will be. So to summarize, I think most of us would agree, as I said at the outset, that the potential is there for improvements in patient safety and increasing the quality, the cost effectiveness, the efficiency of prescribing. But in the outpatient setting so far, the evidence is relatively preliminary. We have some decent evidence on reducing the use of some high-cost medications. We have some qualitative evidence on the efficiency of prescribing processes. And in terms of drug safety, our evidence is really focused in the inpatient setting. So there's a lot of work that needs to be done to accumulate the evidence that we can really make these gains in the outpatient setting. As we're doing that, we should be able to then move to address aggressively the barriers to full adoption to provide the kind of reliable and interoperable systems that will get outpatient providers really using e-prescribing in a sustained and an important way. I'm going to stop there and say thanks. There's going to be time for questions at the end, which of course we'll be happy to field. But thank you all very much for listening, and I'm going to pass the baton over now to Grant Caro, who Bob Mays introduced at the beginning, and Grant will run through now his slides.
Thank you for handing that over, Michael, and thanks to Bob Mays and others for inviting me to present to you today, and thank you all who are out there for participating in today's conference. I'm going to be talking today about electronic prescribing of controlled substances, which is a subset of all e-prescribing that Michael just reviewed for you. I'm going to focus today on issues that are unique to e-prescribing of controlled substances and how our ARC-funded project here at the Massachusetts Department of Public Health can contribute to addressing some of those issues, especially in the ambulatory care setting. Before I get started, I want to acknowledge the assistance and participation of the other collaborators on this project, which include DrFirst, which is the electronic prescribing solution provider, and the principal involved in this project from DrFirst is Dr. Peter Kaufman, the Chief Medical Officer who presented in the previous part of this series in June. In addition, ERX Network is the electronic prescribing network provider covering the transmission of prescriptions in this project. Brandeis University is our academic partner conducting evaluation and survey, and I'll touch on that later in the talk. Berkshire Health Systems in Pittsfield, Massachusetts is our test site, and I'll give you a little bit more detail of what that means later. In addition, we're working very closely with the Drug Enforcement Administration. And as I said, this is an ARC-funded project. So to delineate for you what I'd like to cover in this morning, or this afternoon, I guess it is at this point, is to give you an overview of the current status of e-prescribing of controlled substances, what will be some of the security requirements to enable e-prescribing of controlled substances, at least the principles, not the actual, since we don't know that yet. Then I'll give you a brief overview of the ARC-funded project here at the Department of Public Health, and then conclude with some of our preliminary findings, particularly addressing barriers to adoption and some other expected project outcomes. So some of the challenges that are unique to electronic prescribing controlled substances, and Michael just reviewed for you in general the challenges for all e-prescribing, which also apply, we presume, to controlled substances e-prescribing, although we don't know because it's never occurred. But focusing on e-prescribing of controlled substances, one of the major issues, and Michael touched on this, is currently there's a lack of approved security standards for such e-prescribing, because that depends upon regulations of both the Drug Enforcement Administration as well as the various states, and I'll be reviewing that issue a little bit later as well. The security standards that would be needed for electronic prescribing of controlled substances are a unique challenge because they need to be preventative of pharmaceutical or drug diversion, an issue that isn't usually prevalent for non-controlled substances. Now, just to make sure that we're all on the same page, I just want to define, many of you probably already are aware that drug diversion is when drugs are channeled from licit use to illicit use. And some of the ways that this can be done is through theft or burglary, tampering, which Michael mentioned, stealing or forging prescriptions, doctor shopping, indiscriminate prescribing, and illegal sales of pharmaceuticals and prescriptions as well. Some of the impact of drug diversion is depicted in this slide, and I've tried to narrow it down to just a few key elements. There are certainly many issues, but controlled substances prescriptions constitute a little bit under 10% of total prescriptions in the United States. The issue of using prescriptions non-medically in the United States, it's estimated that there are currently about 7 million individuals who are using those substances non-medically, and that we are adding on the order of over 2 million new users every year, that is non-medical users or abusers of prescription drugs. So it's a huge problem and continuing to get larger. Now, the lack of approved standards for e-prescribing controlled substances has contributed to delay in realizing all the benefits of e-prescribing that Michael just covered. And I won't go into detail here, they're listed, but he just covered that. So in the interest of time, I'll move forward and just say that in addition to those benefits, in terms of controlled substances, there are additional benefits. So we would expect that there would be reductions in the non-medical use that I just described of controlled substances. Michael touched on this issue, that there would be increased adoption of e-prescribing of all substances, including non-controlled medications, because of the multiple systems that would be necessary, that are necessary now with e-prescribing of legend drugs and paper prescriptions or fax prescriptions for many of the controls. So what I'd like to do next is to delineate for you what are the types of security requirements that would be needed for controlled substances e-prescribing. And before I get into the detail, though, just to give a little bit of background, the charge to the Drug Enforcement Administration and to states, both of which act to control substances, controlled substances, is to balance the need to enable controlled substances prescribing, whether it be by electronically or via paper, and at the same time prevent drug diversion. So the standards that are in the proposed rule that was mentioned earlier, and that I'll cover here, are an attempt to balance those two missions. And specifically, DEA and others have identified the security elements that would be needed to find a solution for e-prescribing of controlled substances. And they are covered in the next two slides and include a means for authenticating the prescriber, that is the individual signing and sending the prescription, and as well as those receiving the prescription at the pharmacy. The ability to ensure that those involved in transmission and signing the prescription and receiving it can't deny that they were involved in those activities, and that's for legal issues that I'll get to next in the next slide. There needs to be record integrity, which means that the electronic record we have to be ensured that it was not altered at any point in the transmission. All these elements contribute to legal sufficiency, which means that one has to be able to prove, in the case of a criminal prosecution, beyond reasonable doubt that the activities occurred. One wants signature verification to ensure that the person who signed the prescription meant to do that. And then, of course, we need to ensure confidentiality of the data. Now, all these elements need to be built into an electronic system or electronic systems to ensure that they have at least the same security as a wet-signed paper prescription. In addition, they can offer us an opportunity to even increase the security compared with a paper prescription. Now I'd like to take you through a schematic of how those elements in a security system might be applied to the e-prescribing that you know today. And those of you who may have difficulty seeing this slide may want to go to full screen because some of the type is a little bit small. But right now, the system is that the prescriber sees the patient, writes the prescription. This is for legend drugs, non-electronic, non-controlled. The prescriber enters the information in the e-prescribing system. It's transmitted through an e-prescribing network such as ERX or SureScript's RX Hub. It's then transmitted to, the information is transmitted to the pharmacy system, and there's adjudication with the pharmacy benefit manager in terms of payment, and then transmitted to the pharmacy for dispensing by the pharmacist back to the patient. So this is the current view in terms of e-prescribing today for legend drugs. In order to get to the point for e-prescribing of controlled substances, one needs to impose those elements that I just reviewed for you. And so it would look something like this schematically. In the next slide, let's see here. Okay. In this case, all the green areas indicate what other elements need to be superimposed upon that schematic that I just reviewed in order to ensure security of these systems. And they include credentialing and authentication of the prescriber, some sort of hard token, a security token, to ensure that the prescription is being signed by that prescriber. There needs to be checking of the DEA database of prescribers to have a continuous credentialing of the prescriber, because the initial authentication step denoted here occurs once, and to ensure that the prescriber is still authorized by the Drug Enforcement Administration as well as the state to prescribe controlled substances, one needs to check the database regularly. Another element is that the e-prescribing network as well as the pharmacy would need to digitally sign and archive that prescription. Again, this is to address certain of the elements such as ensuring that there has been no change in the prescription at any point in the transmission. The security token could be, I want to just mention, that means a smart card or crypto key, which is a kind of thumb drive, which would be something that the prescriber would carry. So these are the elements that would need to be superimposed on the e-prescribing system and that we would be testing as part of our ARC-funded project. And I'll go into a little, as I mentioned before, I'll give you a little bit of an overview of the project. And the aim of the project is to encourage the expansion and adoption of e-prescribing, particularly with regard to medication management in the ambulatory setting, by testing and demonstrating the safety, security, quality, and effectiveness of electronically prescribing federally controlled substances in an ambulatory setting. Some of the key elements, as I mentioned, Berkshire Health Systems is our test site. Both Berkshire Health Systems hospitals and prescribers and the Berkshire County pharmacies in the Berkshire Health Systems catchment area provide a laboratory for us to conduct this work. As part of this work, of course, we had to obtain a waiver from the DEA to allow the prescribing of controlled substances, and since it's not permitted by any current regulations now, and that would be limited to our test area. We had to develop systems for the authentication process for the providers, and as part of our study we have been conducting provider and pharmacy interviews and surveys, and I'll give you some preliminary results from that in a moment. Other elements of our protocol include having a hard token for digital signature by the providers, having the prescriptions transmitted electronically and dispensed by the pharmacies, as well, and then evaluating our processes and outcomes. In addition, we're conducting an independent security analysis to test the security of the system that we put together. In terms of the waiver from the DEA, which many of you may be interested in, it was in the form of a memorandum of agreement between the DEA and the Massachusetts Department of Public Health, which was completed in September 2008. The waiver is specific to the project protocol. In addition, as many of you are aware, and Michael touched on this, DEA published a notice of proposed rulemaking in June of last year. And there are some similarities and differences between our memorandum of agreement with DEA and the proposed rule, and I'll go through that in a moment. But before I do, just want to point out that the reason for the MOA, as I said, there are no regulations in place right now, and no state systems or national systems in place to do all the procedures for security procedures that I just mentioned. So because of the limited scope in our project, which will only involve a couple of hundred providers, and that there are no IT systems in place for this, particularly at the pharmacy level, there need to be some differences in how our project will roll out as compared to what might be expected when this goes national with a final rule from DEA. So the next couple of slides detail for you what some of the similarities and differences are, and I have to say this is our interpretation of the proposed rule from DEA, and while we've shared these slides with DEA, they've not specifically edited them, so I would go to the proposed rule itself if you have any specific questions of what it's representing. But as you can see in the first item, there is a difference in terms of the identity proofing, and that this will be done in our case by the vendor and Berkshire Health Systems, whereas the proposed rule would be done by either state officials or hospitals or other agencies. In terms of the prescription information and the authentication protocols, those will be the same. In terms of the prescriber workflow, there are some requirements of the proposed rule, but not in the memorandum of agreement with BPH. In terms of the archiving of signatures, that is somewhat similar, and in the interest of time, I won't go into the details on all of these. You can read them at your leisure. But in terms of checking the DEA database, there is also similarity between our agreement and the proposed rule in that element as well. In terms of archiving signatures, Pharmacies in our project will have the option to wet sign the prescriptions because they may not be set up to digitally sign the prescriptions, but that would not likely be available according to the proposed rule. And then in terms of audits, we weren't required to audit in terms of, as would be expected under the proposed rule, although, as I said, we are conducting independent security analysis to cover that particular aspect. Now, I know that one of the interests in this series is medication adherence and the issues around that, and Michael covered that very well. I'll say that it's a secondary aim of our project to look at that issue, and that's because we were looking at the interfacing between an e-prescribing system that we're developing and the Massachusetts Prescription Monitoring Program. The monitoring program collects records of dispensing of prescriptions for Schedule II controlled substances in Massachusetts from Massachusetts retail, clinic, and outpatient pharmacies. And what we aim to do is to reconcile the prescribing records from the e-prescribing system and the dispensing records that we get from the pharmacies. And our main aim was to look at the issues of drug diversion activity that way, but as a secondary part of that, we may also be able to get a measure of medication adherence. And I'll get back to that topic in a moment, some of our preliminary findings. But before I do, I'd like to cover some of our findings preliminary findings with respect to our prescriber surveys and their perspectives on expectations for electronic prescribing of controlled substances. So for that aspect, Brandeis University team surveyed 246 Berkshire Health System prescribers earlier this year and found that about 43% use e-prescribing now, that is for non-controlled substances, of course, and that controlled substances prescriptions comprise about a quarter of their prescriptions. They further found that about a quarter of the respondents expect controlled substances to be initially disruptive to their practices, that, however, that a large number of them expect that controlled substances e-prescribing will improve quality. About half of them, interestingly, expect the hard token that would be required for the digital signature to be a large inconvenience. And about a quarter of the respondents expect the advantages of e-prescribing controlled substances will not outweigh that burden of using a hard and keeping a hard token. So that's something, a very important barrier that people will need to focus on and address. Of course, this is, again, expectation, and we will be going back to survey the same individuals once we've implemented the hard token and other features and see what they feel about it after that point. Oh, I want to go back, too, and just mention that Michael earlier addressed the issue of providing incentives and value to providers to do e-prescribing, so certainly this is another area in which that would need to be addressed. Another area of possible barriers to e-prescribing controlled substances involves state law. Now, much of the focus to date nationally has been on the DEA regulations, and less focus has been at the state level. However, the state regulations also are a necessary aspect of e-prescribing controlled substances. So, for example, in some states, California, Massachusetts, and New York are examples. There are laws now on the books to allow e-prescribing controlled substances pending the regulations from the DEA. However, in some other states, that's not the case. So, for example, in Florida, Florida law requires a written prescription for Schedule II drugs. And in Texas, the law prohibits e-prescribing of Schedule II prescriptions and requires a manual signature. So those are a couple of examples of laws that would need to be changed in order for controlled substances to be e-prescribed in those states, even with a federal regulation. Now, and there's, of course, there are many issues with that. There's the time needed to change state laws, and that might be significant. In addition, states are not required to enact laws to allow e-prescribing of controlled substances. One expects that they will, but they're certainly not required to do that. And state laws can be more restrictive than the DEA. So although the DEA will come out with requirements, a state does have the option to come out with additional requirements. They can't be less restrictive, but they can be more restrictive. Other issues that we've come across in the course of our study are that many states place the responsibility for security and validity of the prescriptions on the prescribers and the pharmacies. Those are the entities that are regulated and licensed by the states and by the DEA. But the transaction system providers, that is the e-prescribing software providers, those who provide the transmission networks and switches, and the pharmacy software are not regulated or licensed either federally or by the states. So the question arises, how will prescribers and pharmacies be assured that the systems meet the necessary security requirements, since they will have some, ultimately will have at least some legal responsibility for the transaction? Remember the issue that I brought up earlier about non-repudiation. So they'll be a party to the transaction, and how will they be assured that the transaction is actually following all the DEA and state rules? That's a big question, and could be a barrier to adoption if prescribers and pharmacies don't have that assurance. Another item that we came across in the course of our project was that currently third-party payers, including Medicaid, do not allow electronic prescriptions for controlled substances, as you might expect. So this will be an issue that all third-party payers will have to change their reimbursement mechanisms to allow EPCS. In terms of medication adherence, as I mentioned before, part of our project is looking at that, and we'll be reconciling the e-prescribing records with the dispensing records we get in the prescription monitoring program. And what in beginning that part of the project was that will require a key field for linking the two databases. Now, that key field doesn't exist in prescription monitoring transmission standards right now. So we have begun to work with the standard setters to ensure that there is a key field that could be used in the future to do that reconciliation. Now, of course, in terms of medication adherence, prescription monitoring only covers controlled substances, and often not even all the schedules of controlled substances. So I'm not suggesting that this would be a total solution, and certainly filling a prescription is not the same thing as taking a medication. But it may be helpful in certain cases, especially for those patients who have chronic medical conditions and are using a controlled substances chronically. So I see that we're near the end of time for the presentation part, so I'll just close by outlining for you some of the expected outcomes from our project. And now those again are through our findings and our research, to facilitate and expedite adoption and diffusion of electronic prescribing by field testing the security standards that I've outlined prior to and during implementation of DEA's rules, and identifying unexpected barriers and outcomes prior to implementation to, again, facilitate and avoid maybe some of those problems as the systems come online. And we feel that earlier adoption and expansion, diffusion of e-prescribing and controlled substances will lead to improved medication management by ambulatory care clinicians at the point of care, as Michael so well outlined, will increase access to needed pharmaceuticals, particularly by those with chronic medical conditions, and will, we expect, reduce non-medical use and abuse of controlled substances through controlling drug diversion. So I want to again thank our project team, and all the members are listed here for you for your reference. I've also provided contacts should you have any specific questions on the project after this presentation and the question and answer period. And I want to thank you again for your participation and your patience, and I understand there's going to be a question and answer period that both Michael and I will participate in, so I'm going to hand it over now back to Bob Mays to conduct that session.
Thank you very much, Dr. Carroll. We got a number of questions. One thing I want to point out again, because I got a lot of questions about this by folks that came in a little late, we will be making both the slides available as well as a audio recording of this will be available probably within the next couple of weeks, and you'll receive an email letting you know when that is available and the link to that. Another issue that was brought up about the slides is whether or not the full citations that were listed on the slides would be made available, and we'll do that. We'll make sure that that we also supply the full citation of the slides. There were quite a variety of questions. I'm going to start with one that was really looking at, we've talked most of these conferences, and today's conference, we talked about e-prescribing and electronic medication management, really from the formal healthcare side, so from the provider, from the pharmacist side. And, all of us are beginning to live more and more in an electronic world. Many of us fill our prescriptions via the internet. We communicate through an email with our providers and some with our drug management companies or pharmacies. And there were a number of questions around whether or not this adoption of these technologies will offer an opportunity for individuals to become more direct participants in their medication therapy. And will be able to provide information directly rather than the way we're doing it now, which is to infer by doing things such as med reconciliation and that sort of thing. I was wondering if either or both of you wanted to comment on whether you think that that might be where we're headed in the future, i.e. participation by individuals more directly based on these kinds of technologies.
Bob, it's Mike here. I can provide a couple of thoughts on that. I mean, it's an excellent and important question. It seems inevitable that patients will be taking a more participatory role, and one can certainly see in the abstract the potential positives there if you have patients participating more directly, providing information, whether it's when they're potentially requesting a refill of a prescription, when they have a question about a medication. If you have a way to tell directly, if the patient says, I don't want this prescription because it's too expensive, I'm not renewing this medication because it gave me a headache, you're understanding much more about what drives patient behavior and how to successfully treat their conditions. If you have the ability, if they can say, you know, I'm not taking this medication because I don't know why I'm taking it. Well, now you've identified a deficit in patient education that you can try to address. Those all conceptually are helpful. I mean, I think the barriers there are going to be much as with e-prescribing systems for clinicians, designing the systems in a way so that the information, so that it's easy for the patients input information in a way that gets to their providers, whether it's a prescriber or a pharmacist, in a usable fashion, that information can come back to them. You know, the design is not such a trivial issue. And also, I suspect they'll differ quite a bit. I mean, I think there are a lot of patients who do a lot of elements of their healthcare online now, but I don't have hard data for this, but I think that often tracks with age and socioeconomic status. So, for example, it may not be a great solution for our low-income Medicare population who maybe don't have access to all of the online resources that that some other segments of the population might have.
Great, Dr. Fisher. Thanks for that. There were several questions as well around this issue of alert fatigue, and there was interest in knowing what sorts of solutions or sorts of ideas that are being tested or being developed to deal with that, and if there's any of them showing particular promise.
Yeah, I don't have sort of specific ones to hold up, you know, or examples for people. I mean, I've sort of there are a lot of projects in process, and I think a lot of the things that are being developed are, you know, are still sort of not for circulation. I mean, I think there's a great deal of innovation going on by specific companies, either e-prescribing vendors or EMR vendors, trying to find ways to make this work better. I know here in our system here at Partners Healthcare, which is where I practice clinically, they've been doing work trying to identify the alerts that fire very often without having a clinical impact, and trying to eliminate those. So some of it is addition by subtraction. If you can get the noise out there, if you think of this as a signal to noise problem, one approach is to try to get the noise out of there and then see, will people start responding to the signal once there isn't so very much noise. But this is an area where there's a lot of really important work to be done. And unfortunately, we don't have a great answer. There's not a clear sort of best practice of, here's an alert system that really works great.
Okay, actually, I thought of one while you were talking. Perhaps we could tie the alert system to sort of a LexisNexis legal database and flash the average liability award up on the screen every time we send an alert. That might catch your attention. But
it depends on the depends on the environment, I suppose. I mean, people have even talked about sort of the common sense kind of things like you get in a lot of commercial software applications, where you might get an alert, you know, a misspelling or something, and you have the option of saying no and don't show it to me again. You know, e-prescribing systems for the most part don't have that, and we need to think hard. It's not clear that we want to give people the option to do that for every safety warning. Some safety warnings probably do need to be shown every single time, but the clinical discrimination to you know, to determine which those are is a tricky one to do.
Yeah. There were, Dr. Brent, there were a number of questions around the issue of security tokens. One, are there, you mentioned a couple like a card or a thumb drive. Are things like biometrics being considered by DEA, as well as, is the security token going to be, is the hard token only on the prescriber side, or will it also be on the pharmacy side, the dispensing side? Or do you have any idea about where the final rule might come down on this two-factor authentication?
I'm sorry that I'm not privy to any information as to how the rule will come down on this. There was a lot of public comment during the public comment period on this issue. My understanding is that the rule, as proposed in June, would require a hard token. biometrics could be used as one way to have a password to activate the hard token in lieu of having the kind of password that you're used to typing in now. But as I understand it, DEA felt that that was not sufficient for the security needed for an e-prescribing and controlled substances system. You can see the proposed rule itself, and I gave the reference in my slides, has a lot of discussion and detail on this matter, so participants can certainly go there to get a lot of DEA's thinking on the matter.
I think there was also one question, someone wanted to know if there was a timeline for the final rule. Since I'm on the federal side, I can say that unfortunately these things tend to drag on. I know DEA is working on getting a final rule out, but there is no published timeline for that.
Right. I recall, Bob, the second part of the question I didn't answer, which was that will there be a hard token required at the pharmacy level? And no, as far as I know, there won't be. There will be, again, as proposed, there would be a digital signature required, but I don't know that that would involve a hard token. But I'm not, that's, again, something for the specialist to answer.
Sort of related to this are the security approaches that are being considered and were put forward in the proposed rule. How do they compare with, for instance, the approaches to security that are used by the banking industry or other sectors? Is it possible, are they looking at similar solutions, or are they going to have to develop new approaches for controlled substances?
Well, this is an excellent question. As the questioners suggest, billions of dollars, or if not trillions a day, are transferred by banks in a secure manner. And so the question has arisen as to why can't prescriptions be transmitted similarly. But I must say that the issues surrounding prescription go far beyond simple security of the transmission itself, since there are so many steps along the way in which there could be a problem leading to drug diversion, which is the main charge, as I mentioned at the outset of my talk, that DEA and other regulators have to balance while they enable prescribing of controlled substances. So again, I'm not an expert on the banking industry. I think that probably the DEA proposed rule also addressed some of those questions. So I think I'd have to defer to the banking industry to explain how it could work for controlled substance e-prescribing, but I believe that there are unique differences.
Great. Dr. Fisher, there are, of course, we've talked a lot about the prescriber, the pharmacies, the individual patients. How about the role of pharma companies? Have they been involved in e-prescribing, as well as some of the larger drug database companies? How are they playing in this field?
That's a terrific question. And it's important to keep in mind that my answer is from a somewhat narrow perspective as a researcher. So in terms of how people are playing in that field, I'm sure there are plenty of business interactions and agreements that are not part of big research studies, and so I wouldn't know the first thing about them. So keep in mind that the answer is through a limited perspective. I know that there are definitely some pharmaceutical companies that have been interested in looking at electronic prescribing interventions, especially around drug adherence, which is sort of a win-win for everybody, because if it's a beneficial drug, there's a sense that from a clinical point of view, we want our patients to be taking it for their long-term benefit, and of course, if you make the medication, it's good for you if people take it. So I think there is interest there, but I don't know that that I can give you a sort of general overview of a representative overview of what pharma is doing across the board. In terms of I think you mentioned the database companies, that's a really interesting and important point. You know, I think that's an area where there's a lot of potential for really productive innovation because you know, there are several major database companies that provide drug dictionaries and other things that often are the clinical knowledge base behind e-prescribing interventions. And understanding how to make those more narrowly targeted so that you could get at the problem of alert fatigue, so that you could deliver safety warnings that are really what the doctor's looking for and that they're going to attend to, is a major priority. I mean, one of the challenges is that the drug interactions, for example, that are identified as high danger interactions differ across the major commercial drug databases, and that's a real knowledge generation challenge for the field as a whole. So I don't have an insider's answer to the business part of it because I'm not on the business end of it, but I think both of those are areas where there's a lot of productive work that could be done.
And this actually, both of you could probably answer or have an opinion on. We talked some about some of the legal issues, particularly with controlled substances, but what about the liability issues? Are we you know, is this seen by medical insurance companies as being a new area which requires separate liability insurance, or could engender a different level of liability than currently just the prescribing process entails?
This is Grant. Well, very interesting question. I think I touched on that a little bit when I was addressing the issue of the regulation of the transmission of the prescription. So the prescriber end and the pharmacy end are both regulated, but what's in between is not. So that you're correct, the questioners are correct, there is an additional risk there. Now, there are standards being developed that presumably both the transmission providers and the software providers will need to meet that will offer some level of assurance and lower that risk and therefore lower the liability. But certainly it may be, it's a good question, that insurers may be looking at that and seeing if they have to adjust their liability measures accordingly.
Yeah, I think that there's, it's certainly something that people get concerned about and people have raised issues about whether there's liability created with electronic systems if you know more about what patients are taking or not taking. A colleague of mine who's a physician and lawyer looked at this, and there's certainly no legal precedence to date of any enhanced responsibility being created by electronic systems. I think there's the same you know, potential burden of, or potential liability of being responsible for things that your patients may or may not be doing with the medications you prescribe, but those issues could arise whether you were sending the prescriptions electronically, handing them to the patient, or phoning them in.
There's a question about how electronic medication management affects the organizational relationships between both prescribers and dispensers. You know, historically, of course, both groups have been related but separate. So the prescriber, physician, nurse practitioner, what have you, has their workflow and processes. They create a prescription. Basically, they use the patient as an intermediary who carries that over to the dispensing agent, the pharmacy, who also has their processes. And except for callbacks and other sort of communications that are episodic, those two organizations, unless they're part of a large integrated system, but those two organizations go about their business as they see fit. With the introduction of electronic prescribing systems, you now have a potentially much more persistent link between these organizations, and there is, in fact, a potential for what happens on one side to actually have a direct impact on workflow on the other side, and vice versa. Does this, does the introduction of these technologies potentially mean that we'll see a different way that medication therapy is actually going to occur, a shifting of tasks, if you will, different from the way we currently have defined it?
Well, that's a pretty broad but very important question, Bob. I think that in its ideal form, when you think about sort of the promise of e-prescribing that we talked about at the very beginning of this session, there is, you might beneficially make some shifts if you really had a system working well. So instead of a problem being identified after a prescription has been handed to a patient, they've carried it to the pharmacy, the pharmacist has done a check, they call the physician back, you're now several steps removed. A problem is identified right at the point of prescribing, and an alternative decision can be made. What's transmitted to the pharmacist, has already gone through one stage of checking. That's potentially a benefit. Is there a way to make that a two-way street so that some of the clinical expertise of the pharmacist can be accessed while the patient's in there with the physician? I'm not sure that that there's an easy way to do that with current systems, but that's certainly the kind of systematic improvement one would hope might be available. So I think that those being able to change those communications makes a difference. I mean, I think Grant's project, speaks to exactly that. That right now for controlled substances, the law requires us to hand the patient a prescription with an ink signature on it and rely on them to carry it somewhere. And there's all kinds of concerns in there about diversion tampering and many, many other things. Reshaping the communication has the potential to address some of those concerns, but how to do it most effectively is really where the challenges are.
This is Grant. I would just add that many states I mentioned prescription monitoring programs and databases. Many states are using those databases to provide prescribers with information, prescription histories on their own patients, particularly to assist them with those patients who may be at risk or may be showing signs of using controlled substances non-medically. So certainly that's pharmacy information going back to the prescriber at the point of care. Now, much of that is not real time at this point, but that's certainly one of the goals. So that would be one way to have feedback to the prescriber.
Okay, great. I think we're just about out of time for questions, and we're at the end of the conference. I did want to reiterate that for those questions that were not answered either directly or indirectly, because I did group some questions together, those will be looked at by the presenters, and we'll try and get specific answers for your specific questions that we can then post along with the slides and the audio of the conference. And you'll be notified by email on the email address that you supplied with the conference registration when all that will be available, but it should be within the next couple of weeks. With that, I think I would like to thank our panelists, Dr. Fisher and Dr. Caro, and all the participants who have joined us. I hope you got something out of the conference. ARC runs a series of these types of conferences throughout the year, so please keep current on what we're offering next. Hopefully they're beneficial to the range of providers and other interested parties. Again, thank you very much, and have a good afternoon.